首先我先用中文跟大家谢谢致意。我很高兴今天能来到天津，我来自台湾大学台大医院泌尿科。So today I was given a job to talk about the management options in patients with metastatic hormone-sensitive prostate cancer, or mHSPC. Okay, here are my disclosures. Okay, today I'm going to talk about three major topics. First, starting with combined androgen blockade. And second, completed studies in metastatic hormone-sensitive prostate cancer. And the third, I'm going to talk a bit about ongoing clinical trials for metastatic hormone-sensitive prostate cancer. We all know that hormone therapy or androgen deprivation therapy, ADT, has been widely used in the management of patients with advanced metastatic prostate cancer. And it's been there for almost 70 years. ADT comes into two forms, castration and anti-androgens. Castration is to suppress testicular androgens by either medical or surgical castrations. Anti-androgens is to inhibit androgen receptor signaling pathway by competitive binding of the androgen receptor binding site. Now, first, combined androgen blockade. Combined androgen blockade is to combine castration and anti-androgen, hoping to maximally stop the androgenic action in cancer cells, prostate cancer cells. However, most major guidelines in the world actually don't support the use of combined androgen blockade as a routine daily use. For example, NCCN guideline suggested CAB provides modest to no benefit over castration alone in patients with metastatic disease. ASCO suggested ketoconazole or anti-androgens such as bicalutamide may be offered, accompanied by discussion of limited known clinical benefit. EAU recommends that CAB using non-steroidal anti-androgen or NSAA appears to provide a small survival advantage, which is less than 5% versus castration monotherapy beyond 5 years. However, some of the larger trials included in these reviews were methodologically flawed. So it is unlikely that the small advantage is useful in daily practice. And to the extreme, the NICE guideline from England suggested do not offer CAB as a first-line treatment. I believe these statements may be a shock to most urologists in China. However, how about in real world other than China? Eleni just showed us the Advanced Prostate Cancer Consensus Conference in St. Gallen last year, and they're going to have a second one this year. There are a panel of 41 experts from 16 countries. And this meeting is focused on unmet needs in the management of advanced prostate cancer. In Taiwan, we also have done a consensus that is totally based on the same questionnaire generated by the St. Gallen Conference. In Taiwan, up to 1/3 of our patients actually have N1 or M1 disease upon diagnosis. So the Uro-Oncology Committee of Taiwan Urological Association managed to generate a nationwide multidisciplinary expert group. We call it Taiwan APCC. So the question, do you recommend upfront combined androgen blockade in patients with advanced metastatic prostate cancer. And as you can see, most St. Gallen experts and Taiwan's experts do not use or do not recommend combined androgen blockade as a routine use or in the majority of patients. And then completed studies in metastatic hormone-sensitive prostate cancer. We have 3 major studies I'm going to show you. We all know that hormone therapy is very effective in disease control initially. However, the survival outcomes for metastatic hormone-sensitive prostate cancer patients have not significantly changed until about 2 years ago, when charted data were presented. Later on, the Stampede trial data were published, and which also confirmed the charted findings. That is, there is survival advantage in patients treated with upfront chemotherapy added to traditional hormone therapy in patients with metastatic hormone-sensitive disease. However, the 3rd study, GTAC-AFU15 study, did not show overall survival benefit, and I'm going to show you later on. A meta-analysis of the 3 trials together showed a pooled overall survival benefit. Let's take a look at the charted study first. Charted study is a randomized, open-label control study. 790 patients with metastatic hormone-sensitive prostate cancer were randomized into either ADT plus docetaxel or ADT alone, where docetaxel was given at a standard dose that is 75 milligrams per meter square every 3 weeks. Charted study was the first study ever that stratified patients according to tumor volume. In fact, up to 60% of patients in the study had high volume disease, where high volume was defined as visceral metastases and or bone metastases, where there must be at least 4 or more bone lesions, one of which must be outside the axial skeleton. Here is the major results. Primary endpoint was overall survival. And as you can see here, in all patients with ADT plus docetaxel did much better than patients on ADT alone. The median overall survival was extended by over 13 months. If you look at the high volume, patients with high volume disease, the benefit was even more profound. The extension was more than 17 months, almost 1.5 years. And the 17 month was the largest benefit or largest progress we have ever made. However, in patients with low volume disease, there was no difference in overall survival between the 2 arms. So overall survival benefit was significant in all patients as well as patients with high volume disease. How about the subgroup analysis? The improvement in overall survival is observed actually in almost all subgroups, favoring ADT plus docetaxel versus ADT alone. Here shows the grade 3 or more or higher adverse events, and you can expect that. The most common side effects was fatigue. Up to 4% of patients with grade 3 fatigue. There was also a case of sudden death during the period of chemotherapy. Of course, most troublesome side effects are myelosuppression, such as neutropenia or febrile neutropenia in patients receiving docetaxel. Quality of life results were prospectively collected. In the functional score, you can see that patients receiving ADT plus docetaxel actually had a functional loss or reduction during chemotherapy at about 3 months. Interestingly, the emotional well-being subscore did not decrease, but is better than patients receiving ADT alone. And at 12 months, the functional score recovered and is even better than patients on ADT alone. Then what about Stampede Study? Stampede Study, the objective is to identify any new treatments that may improve survival in patients with locally advanced or metastatic disease who are initiating standard of care where the standard of care primarily is first-line long-term hormone therapy. So back in 2005, 3 forms of so-called new treatment were tested: docetaxel, zoledronic acid, and celecoxib. However, later on, celecoxib was removed from the treatment arms. Patient population: newly diagnosed prostate cancer with M1 disease, N1 disease, non-metastatic disease but with high-risk features, or patients who have relapsed after radical prostatectomy or radiotherapy. Primary endpoints was overall survival. So you can see that patients treated with ADT plus docetaxel or standard of care plus docetaxel did better, not only in failure-free survival, but also overall survival. If you look at only the M1 patients, the survival advantage was about 15 months, which is very similar to what we have learned from the Stampede study. However, as you can see, in the subgroup analysis, only patients with metastatic disease benefited from the addition of chemotherapy to ADT. Patients with non-metastatic disease in the subgroup analysis did not benefit from chemo. Additional efficacy also have shown that prostate cancer-specific survival or time to first SRE were better in patients treated with chemo and ADT. Adverse events. You can imagine that patients treated with chemo have more febrile neutropenia or neutropenia. However, most other side effects were about the same between the 2 arms. Then what happened with GTOC-15? GTOC study was the first study to assess docetaxel efficacy in the metastatic hormone-sensitive setting. It was actually initiated in 2004, earlier than Stampede Study, which is in 2005, and Stampede Study in 2006. So 385 patients with metastatic disease, hormone-sensitive, were randomized to receive either ADT alone or ADT plus docetaxel. Primary endpoint was overall survival. Their secondary endpoints included clinical progression-free survival and biochemical progression-free survival. And you can see here the secondary endpoints. Patients treated with a combination with ADT plus docetaxel did better not only in biochemical but also clinical progression-free survival. However, there was no difference in overall survival between the 2 arms. The median overall survival for the 2 arms was about 59 months, 54 months for patients receiving ADT plus docetaxel or ADT alone, respectively. Toxicity-wise, of course, myelosuppression was more common in patients receiving chemo. You can see here febrile neutropenia, infections with neutropenia. And also, there are other chemotherapy-related side effects: fatigue, nausea, vomiting, and so on. So what happened? We can see that the overall survival is better with ADT plus docetaxel than ADT alone in Charted study and Stampede study, but not in GTAC study. The GTAC study was different from the other two studies, at least in two major ways: tumor volume and sample size. Tumor volume was smaller or lesser in GTAC study. If you look at the overall survival of ADT alone group, it was better in GTAC, 54 months, than Charted, 44, and Stampede, 43 months in M1 patients. The percentage of high volume disease was lower in GTAC, 48%, than in Charted, 65%. Another thing is sample size. It was smaller in GTAC. There were only 385 patients than in Charted, 790, or Stampede, 1,700 patients. So there is only a low statistical power with GTAC to detect an overall survival difference. So a meta-analysis have shown that there is a significant overall survival benefit in ADT plus docetaxel than ADT alone in M1 patients and M1 plus M0 patients. So this is the meta-analysis published in European Urology. The combination of the three studies showed that there is a statistically significant overall survival benefit in the combination arm versus ADT alone, not only in M1, but also in all patients. So after the publication of Charted and Stampede data, there have been revisions in major guidelines. For example, the NCCN guideline have included the option as continuous ADT and docetaxel with or without prednisone for 6 cycles. This is one of the options for men with M1 disease. ESMO recommends that ADT plus docetaxel is recommended as first-line treatment of metastatic, hormone-naive disease in men fit enough for chemotherapy. EAU guideline recommends upfront docetaxel combined with ADT should be considered as a new standard in men presenting with metastases at first presentation. However, a perspective from Health Regulatory Authority, NICE guideline, actually did not change a bit in their recommendation for patients with M1 disease or metastatic hormone-sensitive disease. NICE recommends docetaxel as a possible treatment for men with hormone-resistant metastatic prostate cancer. Even after the consideration, they have considered the efficacy and safety of Charted study and Stampede study. So in the real world, as you can see, about 50% of St. Gallen experts and about 49% of Taiwan's experts are actually recommending docetaxel, upfront docetaxel in patients with M1 disease, castration-sensitive, high-volume disease. But they don't recommend docetaxel chemotherapy in low-volume disease. And then in the following several minutes, I'm going to talk about ongoing trials for this specific setting of patients. Here shows the ongoing phase 3 studies with new AR pathway inhibitors in the setting of metastatic hormone-sensitive prostate cancer. And all these studies were designed to test a new agent plus traditional ADT versus ADT alone. And these new agents include enzalutamide abiraterone, apalutamide, and ODM-201, which is another anti-androgen or androgen signaling pathway inhibitor. ENZAMET is an investigator-initiated study testing enzalutamide. 1,100 patients will be randomized to receive either enza plus castration or conventional non-steroidal anti-androgen plus castration, which is the basis of combined androgen blockade. The primary endpoint was overall survival, and this study is currently open for recruitment. Another similar study, ARCHES study, is a sponsored study, and 1,100 patients with M1 hormone-sensitive disease were randomized to receive enzalutamide plus ADT or placebo plus ADT. Primary endpoint, radiographic progression-free survival. And one thing to be noted is that to accommodate the treatment paradigm shift, the inclusion criteria allowed patients who have been treated with upfront docetaxel to be included into the study. Latitude study is to test abiraterone in the mHSPC setting. So 1,200 patients with newly diagnosed high-risk metastatic hormone disease, sensitive disease, were randomized to abiraterone plus ADT or placebo plus ADT. The co-primary endpoints are overall survival and radiographic progression-free survival, just like what we see in the Cougar AA302 study. Titan study is to test the efficacy of apalutamide, or also known as ARN-509, which is very similar with enzalutamide in terms of molecular structure and its mode of action. So 1,000 patients will be randomized to receive either apalutamide plus ADT or placebo plus ADT. And primary endpoint are radiographic progression-free survival and overall survival. PEACE 1 study is very interesting. It's like the Latitude study, not only to investigate the efficacy of abiraterone in this setting, but also to look at local radiation therapy, where local RT refers to prostate radiation, primary tumor radiation, up to 74 gray in 37 fractions. 900 patients will be randomized to either of the 4 arms. The base of these arms are ADT plus with or without docetaxel. So patients who have been treated with docetaxel or not can all be included into the study, and this is the base. The other 3 arms are the base plus abiraterone, or the base plus radiation therapy, or the base plus both abi or radiation. Primary endpoint, overall survival and progression-free survival. ARISON study is to look at another new drug, darolutamide, also known as ODM-201, for metastatic hormone-sensitive disease. 1,300 patients will be randomized to receive either darolutamide plus ADT plus docetaxel or placebo plus ADT plus docetaxel. So all patients, all subjects in this study must have been treated with docetaxel upfront. Primary endpoint, overall survival. However, this study, I believe, is going to be open for recruitment, including Taiwan. So conclusions today. Treatment landscape for metastatic hormone-sensitive prostate cancer has changed significantly in the past 2-3 years. ADT plus docetaxel chemotherapy may become the mainstream treatment for patients with metastatic hormone-sensitive disease. New generation AR targeting agents may have a role in the treatment of metastatic hormone-sensitive prostate cancer. Thank you very much for your attention.
Okay, Professor Pu, please take a seat. We'll have our next panel discussion. You're the panelist. Thank you very much, Professor Pu. You have given a nice presentation. I mean, now we open to the audience for discussion. Any questions from the floor? Okay, please. Okay.
I hope you can hear me. Excellent presentation. I would like to ask you about your opinion about the use of docetaxel in hormone-sensitive patients in Asian population. I think
Sorry, can I go close to you, just like Eleni does?
Okay, please.
Well, it's okay.
Face to face.
All right, please.
Now, my question, excellent presentation. My question is about.
Have you turned it on? Oh, it's okay.
Now, the question is regarding the experience or evidence to support the use of docetaxel in Asian patients with prostate cancer. I think we have seen a lot of data coming from Europe and the US, but what is your opinion about that?
Okay. The question is about the experience in giving docetaxel chemotherapy in patients with metastatic hormone-sensitive disease, the experience. As far as I know, the indication of giving chemotherapy in patients with metastatic hormone-sensitive disease has not been approved in any countries in the world, even in Europe or in the States. It's still an off-label use. Of course, one thing I don't know is whether it is reimbursed in some countries. In Asian countries, of course, it is totally an off-label use. In Taiwan, in about 30% of patients with this setting, when they are recommended with upfront chemotherapy, they would accept and they undergo chemotherapy. About 30% of metastatic hormone-sensitive and fit patients. And about 70%, the other 70%, they don't receive chemo either because of the fear of chemotherapy side effects, and also they are not fit, or their doctors or their urologists, oncologists don't even recommend. They don't even recommend chemotherapy. So as I just showed you a slide, only half of our urologists or oncologists in Taiwan do recommend upfront chemotherapy. And that's just exactly the same as the experts in the St. Gallen meeting. So only half of experts, but that was last year. I'm not sure whether the trend has been changed this year. Yes.
Okay, thank you. Any questions further? Okay. No? Okay. Okay, I'll ask you a question, Professor. In fact, I've asked a question to Professor Lennon. Yeah, just now you maybe after maybe your recommendation may be changed just maybe 1 year earlier and now. In a routine clinic, I mean, for metastatic hormone-sensitive prostate cancer, you prescribe your patients to receive combined ADT plus chemotherapy. And when are you going to recommend them to use, abiraterone and enzalutamide in your routine clinic?
You mean abandon enzalutamide or abiraterone?
No. I mean, for metastatic hormone-sensitive prostate cancer in your routine clinic, you were first recommended to receive combined ADT plus chemotherapy, just according to Charted or Stampede data. Or And when are you going to use, abiraterone?
Oh, okay.
Enzalutamide?
When do I recommend
Yeah.
Abi or Enza? We still are waiting for data of Enza or Abi in the treatment of hormone-sensitive disease. As I just mentioned, there are ARCHES study, there are Latitude study, and there are PEACE 1 study. And so right now, we are still recommending Abi or Enza in patients with castration-resistant disease. And the chemotherapy, the upfront chemotherapy was given to patients with hormone-sensitive disease. So patients in Taiwan actually are receiving Abi or Enza not in a clinical trial setting. They are receiving Abi or Enza when they enter clinical castration-resistant disease.
Okay, thank you, Professor Pu. Any questions? Okay, please. Last one. Okay, please.
Thank you to Professor Pu for a very good talk. My question is regard to the response for high volume disease. What is your thinking that these patients respond? Is it because purely of tumor volume, or is it a reflection of the underlying biology like the phenotype? Do you have data regarding whether patients with poor prognostic factors such as the squamous cell or differentiation or neuroendocrine factors may play a factor in this?
Okay, this is a good question. It's about that why high volume disease respond, but low volume or other groups of patients did not respond to chemotherapy. Actually, I don't know. I don't know how to answer the question. However, there may be some guess. For example, patients with high volume disease may have a much higher heterogeneity in their tumor cells. They probably will not respond very well to ADT or newer ADT. Chemotherapy may become because it is cytotoxic, it may become effective when there is a combination of heterogeneity. I'm not sure if I answer your questions, but we still don't have the answer yet. Eleni, do you have any comments?
Okay, you can use the microphone. Okay. Oh,
Here you
okay.
go.
Okay.
Here you go.
So this is a very interesting topic. I think we're going to talk about it right now when we get up there. But I will just take a minute to dismantle and criticize completely this whole pooled analysis. So what they did is they took a failed study, because you mentioned very well that it might have been because it had lower volume disease in the sense of less disease, and patients in JET2 trial lived longer. They took the Charted trial, that is a trial that was based actually on going for high volume, but it also had to include low volume, and we just heard at ESMO that low volume did very poorly with the docetaxel addition in all survival and quality of life measures. And then they took the Stampede trial that arguably has a major flaw. Only 35% of patients who only got ADT went on to receive docetaxel. And because we like, and that's medical oncologists, not urologists, so I take responsibility to lump everyone together because we like our little boxes, we decided to do a pooled analysis that only shows like a 10% survival benefit, talking about, the bicalutamide paradigm that we trashed. So it's 3 years ago we hated chemotherapy, now we're enamored with chemotherapy. But I think that the bottom line is what everyone is alluding to, that this is a heterogeneous disease. So it's never going to work out by lumping everyone in one or other direction. We have to do better. And I think that's what you're giving in Asia the opportunity to do, to actually look at it in more detail.
All right.
Okay.
Thank you, Eleni.
Okay, thank you, Professor Allen, Professor Pu.